Muy bien, bienvenidos de nuevo a ARI23 y tenemos una interesantísima sesión sobre el queratocono. Lo titulamos Queratocono 2023 precisamente porque si algo ha caracterizado el queratocono en estos años es haber evolucionado hasta llegar a un punto en el cual tenemos un nuevo tratamiento del queratocono que no tiene nada que ver con lo que hacíamos hace 15 o 20 años. I want to thank all the speakers, the very distinguished friends and international experts on the topic, and I'm sure that we're going to enjoy a marvelous session. My co-chairperson, Miguel Maldonado, will introduce the first speaker.
We have the pleasure to have Fahad Hafezi with us. He is going to speak about an update on new protocols and technologies.
Hello, this is Fahad Hafezi from the ELSA Institute in Switzerland. And let me give you a brief update about newest trends and technologies in the corneal cross-linking field to treat keratoconus. These are my financial interests, and today, for the sake of time, I will focus on two new developments, Epi-on and customized cross-linking of the second generation, PACE. Let's start with a technique to stabilize keratoconus, Epi-on cross-linking. The advantages of not removing the epithelium are very obvious. If you do not remove the epithelium, you will have a faster recovery time, less risk for infection, less pain. And if you don't even remove the epithelium, we should not call cross-linking a surgery anymore. It's a procedure that does not necessarily require an operating theater, that can also be done office-based. Now, when you look at the history of Epi-on, unfortunately, Epi-on had a very hasty start back in 2009 when Boxer-Wachler and Pinelli proclaimed that Epi-on is the Dresden Protocol without removing the epithelium. And this very first Epi-on protocol could not work because of the lack of oxygen in the tissue and because riboflavin could not even penetrate through the epithelium. So since 2009, there was a continuous quest to improve Epi-on, but during all these years of improvement on the scientific basis, many Epi-on procedures had already been performed in the field, which leaves us with a technology or a technique that now has gained a certain amount of bad reputation, if you wish so, in previous years. But the good message is we today have a very effective Epi-on, but the road was bumpy, and as I said, it was brought to the field in a too hasty manner. In such a hasty manner that the father of cross-linking, Theo Seiler, along with others in the field like Paolo Vinciguerra, Brad Randleman, and myself, we had to make a very clear statement back in 2018 so that ineffective Epi-on protocols would not further be used. But then around 2018, 19, and 20, finally, we had the first efficient Epi-on protocols. For example, this one here that uses oxygen goggles, 100% oxygen. This was a trend that was introduced by industry to overcome the oxygen issue in Epi-on cross-linking, and others already some years previously introduced iontophoresis to overcome the question of riboflavin saturation. So there finally there were protocols that were real Epi-on, but the only drawback is that then all of a sudden, instead of having a simple and elegant technique, you have a still elegant but very, very technology-heavy technique. You need a cross-linking device, you need a iontophoresis apparatus, and whoever has done iontophoresis knows how fiddly this can be. It may burn the patient, you can lose the suction of the ring, and the riboflavin is everywhere. You need an oxygen tank, oxygen goggles, so very technology-heavy. So the question was, is there any means to keep this well-functioning Epi-on without the need of additional oxygen and without the need of iontophoresis? And the answer is yes, we finally have it. On one hand, we were able to remove the need for additional oxygen and just work with the 21% of oxygen we have in our normal atmosphere. This was done by This was initial work done by Cosimo Mazzotta from Italy, and he also increased the fluence, he pulsed the light, increased the intensity, and did a gentle acceleration, and by these technical settings he was able to overcome the need for additional oxygen. He published 3-year data which were very successful. However, Mazzotta still needed iontophoresis. So our group tried to remove the need for iontophoresis, and we did this by, on one hand, increasing the total fluence even more, and by introducing what we call penetration enhancers of the second generation. So substances that allow the riboflavin to pass through the epithelium without damaging it. There was a first generation of penetration enhancers in the mid-2010s. They were effective, but they were too effective, meaning that the next day after an epi-on cross-linking performed in 2013 or 14 with first generation enhancers, the cornea would have a damaged epithelium. So this was a hidden epi-off procedure. We managed with our group in Zurich to tweak these settings of the penetration enhancers using multiphoton technology. This took us more than 1.5 years at the Swiss Federal Institute of Technology. And finally, we arrived to have a composition of penetration enhancers that gives you very strong riboflavin saturation, as you can see in the lower right, without damaged epithelium. So it was like putting the pieces of a puzzle together, and finally we have an epi-on that is elegant again, no need for oxygen, no need for iontophoresis. And the best news is, in the laboratory, this new epi-on is just as strong biomechanically as the 10 minutes epi-off. If you look at the fluorescence, there is a strong fluorescent signal, but of course we also verified this not only by looking at it, but with the multiphoton microscope. And we have a clinical trial going on with a very nice demarcation line around 230 micron. And this is how we perform epi-on cross-linking nowadays. As you can see, this is not an operating theater. So this is the news from cross-linking to stabilize keratoconus. Let's look at something entirely different. Cross-linking to improve vision in keratoconus. We call it PACE. If you perform a standard cross-linking in a progressive keratoconus case, then you aim at stabilizing the cone, right? As you can see here 1 year after. Now this is customized cross-linking of the second generation. And if you look at the central cornea, it is not stable, it is massively improved, and the cornea is regularized. Here is another example, before and after. How many weeks or months after? PACE? 1 week after PACE. So this is a massive improvement. And if you compare this to the best we can do with excimer laser ablation, we are just as good, and sometimes even better, without removing a single micron of tissue. This is not an excimer-based ablation where we use corneal stroma. No stroma removed. How did we do this?
The CI device is extremely versatile.
We did this by combining our CI technology that now can be found under the Schwind Amaris excimer lasers. So by doing so, we had 3 technologies that we used: the Amaris, our CI technology, and the epithelial maps from CSO Italia. We call this PTK-assisted customized epi-on cross-linking. And we have already treated more than 100 eyes with a 1-year follow-up. Next year we will publish our data. So let me give you a rough overview, but not the complete story before we have published it. So what we do is we create very powerful gradients. First, I remove the epithelium over the tip of the cone with a very specific customized epithelial map guided PTK. So I stay within Bauman's membrane. I don't use the excimer laser here to remove tissue. I use it as a very, very precise knife to only remove the epithelium staying in Bauman's layer over a certain area of the cornea. And this gives me a certain gradient between epi-off and epi-on. If I treat the whole cornea now with one light regimen, the epi-off area will react stronger. And then I create a second gradient. If I now treat the whole cornea with riboflavin, and the epi-on area is our very strong epi-on, but still the riboflavin will penetrate more easily over the denuded central area. So the riboflavin goes into the cornea and to the sides and creates a gradient of concentration between center and periphery. There will be more riboflavin over the cone, and there will be more cross-linking reaction. And finally, I will specifically treat the small PTK area with even higher fluence. So 3 gradients that make that the center of the cone will be treated more than the periphery. And this is how it looks like during the treatment. You can see strong fluorescence from the epi-on and even stronger fluorescence from the epi-off area. And the results are very, very interesting, and they make us very enthusiastic. And look at this, before and 1 week after PACE. Now the beauty of this is, in an excimer laser procedure, I only remove tissue, like Athens protocol, Cretan protocol, STERX, TREC. So I can only reduce the Kmax over the tip of the cone. But in such a procedure, let me give you a different example here, before and after. Look at the difference image in the upper middle. I do not only remove tissue here. Let me go back. I do not only remove tissue, but if I press the tissue in, if I flatten it over this area, the upper area has a coupling effect and steepens. And this you never see with an excimer laser. So we do not only flatten the Kmax, we regularize the cornea, sometimes by up to 12, even more diopters. This is another example, 3 months after PACE, and you can see much more symmetry over the central cornea. Here's the difference image. And if you scroll through the effect over time, you see that after 3 months, massive improvement, no tissue removed, and this improvement does not change substantially after 6 months. It stays stable. And again, here is the difference image where you can see how much improvement we can get. And the demarcation line follows that pattern because it is way deeper over the tip of the cone. So in conclusion, we have immediate regularization of up to 12 diopters. We sometimes gain 4, 5, even 6 lines of CDVA. And because I have not removed tissue, nothing keeps me from trying to do doing a wavefront-guided, corneal wavefront-guided PRK at a later stage in time. And also, we can use this in stable keratoconus. So not only in a patient who comes in and says and is progressive, but in a 35-year-old patient that tells you, I've been stable for a number of years. I had contact lenses for many years. I don't tolerate the contact lenses anymore, and my vision with glasses is not sufficient. This is a perfect patient for PACE. If you want to learn more, please visit us in December in Zurich. Thank you very much for your attention.
Thank you very much, Fahad. Excellent. It is a new perspective on the use of cross-linking. And now let's move to the next presentation that will be performed by George Kimionis from Greece about the combined treatment of cross-linking with excimer laser customized PRK. Thank you, and George, you are the next one.
I would like to start my presentation with one of my very first patients treated back to 2005. So this patient had progressive keratoconus, low visual acuity, both are correct and best correct, and she had also contact lens and spectacles intolerance. So at that time, back to 2005, we thought that the best treatment option for her was the cross-linking. A year later, you can see a very nice outcome. Actually, we stabilized the progression of keratoconus with slight improvement in cornea topography. I was happy with the result, but still the patient was unhappy. And this is because she still had contact lens and spectacles intolerance. So at that time, we realized that the majority of the keratoconic patients after cross-linking, even though we cured the disease, we stabilized the progression of keratoconus, they couldn't achieve functional vision, especially those that cannot tolerate spectacles or contact lenses. So we can cure the disease, but still the patients are not happy. And then we start thinking about the cross-linking plus. What is the cross-linking plus is the combination of refractive treatments like rings or phakic refractive lenses in combination with the cross-linking in an attempt not only to stabilize the progression of keratoconus, but also provide to our patients functional vision. It was logical to start with the tissue-saving approaches like conductive keratoplasty, rings, or phakic refractive lenses. Here you can see an example, a patient treated with conductive keratoplasty, an old approach of refractive surgery in order to treat hyperopia. So we just placed few spots of radiofrequencies in the flat meridian of the cornea in an attempt to decrease the cornea irregularity, and then try to freeze this effect using the cross-linking. The problem with this approach is that we have only temporary effect and significant regression. The second attempt was to use rings. You can use Intacs, Kera rings, or sometimes both of them, like in this patient, in order to decrease the cornea irregularity and then freeze this effect using the cross-linking. The problem was with the rings, we cannot achieve predictable results. The third attempt was to use phakic refractive lenses. Phakic refractive lenses is a very nice option in keratoconic patients because we can treat high myopia or astigmatism. But the problem is we cannot treat irregular astigmatism, which is the case in keratoconic patients. So many options, but still not predictable results. And I think that everybody will agree that the most accurate device, not only in ophthalmology, but in medicine, is the excimer laser. The problem is who has the guts to ablate a keratoconic cornea. And back to 2009, we published our very first case series of patients with keratoconus treated with simultaneously topo-guided PRK cross-linking. Very good results with significant improvement in the best-corrected visual acuity, significant improvement in topographic irregularity, but the major limitation of the combination of topo-guided PRK and cross-linking is that it's not applicable in the majority of keratoconic patients. Only a few patients at the early stage of disease are applicable for this approach. And this is because, remember, after you finish the topo-guided PRK, you have to leave more than 400 microns in order to perform the cross-linking in a safe way. So the more tissue we ablated, the more the side effects, like here, deep cornea scarring or progressive cornea flattening in this patient that could end up with significant amount of hyperopia. So we need the accuracy of the laser in order to decrease the cornea irregularity by removing small amount of cornea tissue in order to avoid the side effects. So instead of doing topo-guided PRK and cross-linking, instead of combined topo-guided PRK and cross-linking, it's better to use and combine transepithelial phototherapeutic keratectomy with cross-linking. And the rationale of the combination of transepithelial PTK cross-linking is that we all know that the epithelium in the keratoconic patient acts like a masking agent. You can see an example here in this topography. The epithelium at the area of the cone, it's thinner than the rest of the cornea. So instead of mechanically or alcohol removal during the cross-linking, if you ablate it, then you remove a small amount of cornea tissue at the area of the cone, few microns, and then you decrease the cornea irregularity. So a decade ago, we published our first patients treating with a combination of PTK and cross-linking. You can see a significant improvement if you compare with the mechanical epithelial removal, significant decrease in cornea irregularity, and also significant, you can see an example here, a year later, significant improvement in cornea topography, and also a stabilization of this effect without progressive cornea flattening. So the advantage of this approach over the topo-guided PRK is that it's applicable in all keratoconic patients suitable for cross-linking, in contrast with the topo-guided PRK, which is only applicable in the early stage of keratoconus. It's easy procedure. We don't need all of these fancy and expensive devices that they relate to the topography, the tomography with laser. It's simple approach. You just remove 45 up to 50 microns using the transepithelial PTK. There are no side effects. We just remove few microns of the area of the cone, and you have a better epithelial healing with less pain due to the smoother edges of the deepithelialization. So the combination of PTK and cross-linking, what I call the epithelium guide cross-linking, it's not only better than the standard cross-linking, but the best treatment option for keratoconic patients suitable for cross-linking. Thank you so much.
Thank you.
And now Dr. Maldonado will present the next speaker.
Next, Dr. Hashemian is going to speak about intracorneal segments, when use them and which ones use.
Hello, dear colleagues. I want to present the effect of intracorneal ring segment implantation in the management of the keratoconus, when and which ones. The modern treatment options in mild to moderate keratoconus are contact lens, intracorneal ring segment implantation, phakic IOLs, and combination of these methods. The history of using intracorneal ring segment back to 1997 by Professor Collin. To use intracorneal ring segment, we have to know about the design and profile, type, thickness, arc length, material, mechanism of action, indications, nomogram, and the safety and efficacy of this procedure. The objectives of this procedure are to regularize the corneal surface, stabilize or delay ectasia progression, and to reduce the refractive error and improving the best corrected visual acuity. The intracorneal ring segments affect the keratoconic cornea in two ways: flatten the central cornea, and by shortening the path lengths of the collagen lamella central to the segments, redistribute the corneal stress. Intracorneal ring segments are available in various arc lengths, cross-sectional shapes, thickness, and diameters, and the most popular ones are Intacs, SK, Keraring, SI6, Ferroring, and Myoring. The intracorneal ring segment effects depend on thickness, diameter, and arc lengths. The indications include keratoconus with grade 1 to 3, pleucid marginal degeneration, iatrogenic ectasia, and the treatment of corneal irregularity after trauma. The best candidate for intracorneal ring segment implantations are age over 18 to 21 years a clear optical zone, corneal thickness greater than 400 micron in the thinnest location and greater than 450 micron in the area of implantation, corrected distance visual acuity worse than 0.6 and better than 0.2 decimal, and mean keratometry less than 58 diopter, and the least alignment between refractive corneal and coma axis of astigmatism. The mesopic pupil size less than 6.5 millimeter, and the contraindications are advanced keratoconus, corneal opacity, low endothelial cell count, and the high expectation, and also thin cornea, and in patients with collagen vascular autoimmune or immune deficiency disease, in pregnant or nursing women, and in patients who taking some drugs such as Accutane. This data required for surgical planning are subjective refraction, best-corrected visual acuity, topography and tomography, especially tangential map, anterior and posterior elevation, pachymetric map, coma map and coma axis, mesopic pupil size, determining the steep axis, consider the corneal asymmetricity and select the appropriate nomogram and 5 millimeter or 6 millimeter optical zone segments. To choose one segment or two segment or asymmetric segments is based on mean refractive error, amount of astigmatism, cone location, asphericity value, coma axis, and amplitude misalignment between the topographic and coma axis and mean keratometry. The other approach is the according to the axiality and symmetricity of the keratoconus pattern, and you can see in this slide the different pattern of the keratoconus. The important parameters are cone location, coma axis, and the disparity between the coma axis and topographic axis, and also asphericity. In patients with central cone and the myopia higher than astigmatism, two segments is recommended. And in patients with eccentric cone with the astigmatism higher than myopia, one segment, and also in asymmetric cone with myopia equal to astigmatism or astigmatism higher than myopia, two asymmetric cone is recommended. And in patients with the high astigmatism and astigmatism associated with hyperopia, we have to choose shorter arc lengths, and with central cone, two short arc lengths, and in eccentric cone, one segment is recommended. And we can use also the nomogram of the manufacturer and put the all parameters and choose the best segment for each patient. We study about the effect of one segment or two segment. The one segment result showed induces 1 diopter of hyperopia and 1.5 diopter of astigmatic correction, and two segment induces about 3 diopter of hyperopic shift and 1.1 diopter of astigmatic correction. For the surgical planning, incision site usually on a steep axis, and the best technique for channel creation is the femto-assisted laser surgery, because the femtosecond laser provided the precise channel and keratotomy depths, widths, and location. And in rather to mechanical tunnel creation, it's more precise and predictable. We can choose the center of the geometric or the center of the pupil, and with the creation of the precise tunnel, and very easily put the segment in the best location, and so have a good result and better and less complication in rather to mechanical channel creation. To review these parameters, I present the two cases. In the first one, 38-year-old female with the history of LASIK 20 years ago that referred for the decrease of visual acuity in the left eye, the best corrected visual acuity 20/60, and the refraction -2 at 100, and as you can see on the imaging by the orb scan and MS39, in left eye, ectasia was occurred and with the eccentric cone. And so, according to parameter, I input one segment in tax escape 400 thickness and 150 degree. And after 2 weeks, the uncorrected visual acuity increased to 20/30 and best corrected 20/25 with 0.75 diopter of astigmatism. And in case 2, that refer for decrease of vision in both eye with the infratemporal ectasia in both eye, relatively regular. And so according to the refraction, that astigmatism higher than myopia, and elevation and keratoconus pattern, I decide to put one segment in tax escape infratemporally in both eye, and after the operation, the cornea regularized and the best corrected visual acuity improved to 20/25 on right eye and 20/40 on left eye, and very good result. In general, the effect of intracorneal segment are the 2 to 4 line improvement in uncorrected, 1 to 2 line in best corrected visual acuity, 3-4 diopter of the reduction in spherical equivalent, and 4 to 5 diopter reduction in keratometry, and also mild reduction in astigmatism. The complications are explantation, repositioning, corneal neovascularization, corneal melting, extrusion, infection. And so regarding to the improvement in technique and nomograms, if we consider the best surgical technique and the nomogram and the case selection, today's we have less complication and with good predictable result by this procedure. Thank you very much for your attention.
Thank you very much, Ayed, and it's my pleasure now to introduce our last speaker, Lal Danasuri from Riyadh, Saudi Arabia, phakic lenses in the treatment of keratoconus. Thank you.
Ladies and gentlemen, I'm Lal Danasuri. I'm happy to participate in this recorded session. Thanks for the invitation. My topic today is the use of ICL in eyes with keratoconus. I'm consulting to Star Surgical, the manufacturer of the ICL. The indication of ICL in eyes with keratoconus is very simple and straightforward. ICL can be an excellent modality to correct any ametropia in eyes with keratoconus, provided that the ectasia is stable, corrected distant visual acuity is satisfactory, and the quality of vision is acceptable by the patient. There are many ways to assess stability of keratoconus, whether you're using placebo, Scheimpflug imaging, or an OCT. Changes of the anterior surface of the cornea over the years is a great tool to assess stability, like in this case, where the keratoconus pattern, the simulated K and the maximum K, also the corneal astigmatism, are stable over 5 years. The posterior elevation is also important to monitor before we diagnose stability of keratoconus. As you can see here, over the years, the posterior elevation map is stable. Also, the corneal thickness map gives you a very valuable information about stability. A stable keratoconus will have stable corneal thickness over the years. The epithelium is too sensitive to changes in the curvature gradient, so stability of the epithelial thickness map is an additional parameter to confirm stability of keratoconus. So in order to diagnose stable keratoconus, we have to have all these parameters stable for at least 1 year. Curvature map, anterior and posterior, thickness map, corneal and epithelial, also the manifest refraction and the corrected distant visual acuity. Now, the second criterion for patient selection is a satisfactory quality of vision. Subjective assessment of quality of vision is very valuable. However, I found that the MTF curve is the simplest, fastest, and most reproducible objective measure for the quality of vision. In this example, the MTF graph on your left-hand side is low, denoting a poor quality of vision. And this eye is not a good candidate for an ICL, while the curve on your right-hand side is high enough to anticipate a good outcome after ICL surgery. These are three examples of eyes with keratoconus at different stages. All of them have a good quality of vision, 20/20 or better, but not all of them are good candidates for ICL. The top one has a reasonable high-order aberrations, an excellent high-order MTF curve, and much lower low-order MTF curve. This is an excellent case for ICL, as the ICL will close this gap between the low-order and the high-order MTF graph, and the patient will appreciate the difference. The second case in the middle also has a more advanced keratoconus, higher order aberrations, but still the high order MTF graph is good enough to anticipate good results. The third example at the bottom here has a moderate keratoconus with 20/25 corrected distant visual acuity. High order aberrations are higher, and both low and high order MTF curves are low. So there is no room for improvement, and this patient will not appreciate any improvement of vision after ICL implantation. So this is not a good candidate for ICL implantation. Now I'm going to share with you some clinical results. This was a prospective study we did many years back. We included patients with stable keratoconus, 19 eyes, patient post-cross-linking and approved stability for at least 1 year, 23 eyes, and patient post-intracorneal ring segments, there were 4 of them. All these patients received an ICL or toric ICL, and at 1 year, the mean uncorrected distant visual acuity was significantly improved. Also, the corrected distant visual acuity significantly improved because many of these patients have high myopia, so the patient benefit from the magnification of the retinal image with the implantation of a negative lens inside the eye. The predictability at 1 year was very good, very similar to the predictability with ICL in normal eyes. Now, as for the volt of ICL at 1 year after the surgery, we had 72% of our patients had a volt between 250 and 750. This is the optimal volt. 96% had acceptable volt between 100 and 1,000 microns, and only 4% were outliers, 3% with high volt and 1% with low volt. This is an example of a patient with moderate keratoconus and high myopia. The anterior surface is more or less regular with satisfactory corrected distant visual acuity. His keratoconus was stable for more than 2 years. This is a great case for toric ICL. This was implanted, as you can see here. Post-operatively, the myopia is corrected, and most of the cylinder was corrected also. Note that the internal astigmatism induced mainly by the ICL is on the orthogonal meridian relative to the corneal astigmatism. That's why the cylinder correction was very accurate, and the patient is enjoying a very satisfactory uncorrected visual acuity. Another clinical example with the progressive keratoconus and acceptable corrected distant visual acuity. This patient had a cross-linking, and then we waited for 2 years for stability before implanting a toric ICL. And below here you can see the outcome 3 years after cross-linking and 1 year after toric ICL. The cornea is stable, high-order aberration did not change much. The OPD, the optical pulse difference, which measures the objective refraction, improved to almost plano, and the low-order MTF improved significantly to match the high-order MTF, and the patient is very happy with the quality of vision and the uncorrected visual acuity. Another example, but here the cornea is very irregular, unacceptable corrected distant visual acuity. So this is a good indication for intracorneal ring segments. Now, 1 year after implanting the ring segments, the cornea is much more regular. Corrected distant visual acuity and the quality of vision improved significantly. So this is the time to implant an ICL. and you can see here the ring segments are in place, and patient is satisfied with the outcome. In cases with advanced keratoconus and highly irregular cornea, DALK is our first choice. This patient received a DALK, sutures removed at 1 year. We wait for 3 months after removal of suture to confirm the refractive stability. Here the patient had 4 diopters of corneal astigmatism, so we decided to implant a toric ICL. The calculation was done as usual using the OCAS calculator. And this is the post-operative results. All cylinder was corrected by the ICL. The outcome is cylinder is 0. Patient can see 20/20 without correction. Toric ICL is properly aligned. This is an excellent result for such a case with an advanced keratoconus. So in conclusion, ICL is an excellent option for correction of ametropia in eyes with stable keratoconus and satisfactorily corrected distant visual acuity. ICL can be used for stable keratoconus also after cross-linking intracorneal ring segments or DALK, and patient satisfaction is extremely high. And I thank you for your kind attention.
Thank you very much, Ala, the excellent talk. And now we have a panel of experts that are going to debate about the question is when a keratoconus is with a surgical indication. So far, we have been seeing presentations that have demonstrated that refractive surgery in keratoconus is therapeutic because we can improve the binocularity and to gain best corrected visual acuity in these patients. We know that with segments we can mold the cornea, and we know that even therapeutic indications for examined laser are feasible with good results. So all these, let's say, new surgeries are at this moment available, and the question is, when is corneal graft or other types of more invasive surgery indicated? Let me invite now to Teo Seiler, Paulo Vinceguerra, Miguel Teus from Madrid, and Luis Cadarso, if available, just to make this discussion and to participate live in this session. Can we have the connection? Thank you.
Yeah.
Very good. So we have a very interesting debate with all the panel members and also the debate of the patients. So my first question now probably is to Fahad. Because Fahad, you have presented your evidence about cross-linking. Cross-linking has changed completely the fate of keratoconus, and now less and less keratoconus are prone to have corneal transplantation, corneal graft. So for you, in your indication, when a case has an indication for corneal graft and not for the different sophisticated techniques that we have been studying today?
Dear Jorge, this is indeed, I think, the most important question we all ask ourselves now with the emerging of the new techniques. I think, above all, scleral lenses have pushed, for me, the indication for a graft very far out, because if we stabilize by cross-linking, good-fitted, well-fitted scleral lens does wonders to the eye. We have cases where even with K-max readings of 160 diopters, 160, we were still able to achieve useful reading vision and a far vision of 0.5, which is just amazing. But I think what is interesting is we have unspecific means to stabilize the cornea, like cross-linking. We have unspecific means to improve to flatten the cornea with customized cross-linking. We can do the final fine-tuning with the excimer laser. And now above even PACE, we have femtocares that is able to flatten the cornea, again, unspecifically by 10 to 15 diopters, up to K-max readings of 70. So I think we are pushing the frontier over which keratoplasty is needed further and further out, which is, I think, very interesting.
But Jorge, I think
in other words, yes, please.
But I think that the corneal graft is anyway possible if you proceed with other means. So not the opposite. So it is fair to try something that preserves the cornea. I still do graft when the cornea is in one area extremely thin, let's say 90 micron, 80 micron. So that is even dangerous for small trauma to leave a cornea so thin, because if you have 80 micron of remaining stroma, is very, very thin.
Yes, Paul, but if you have a patient that has BCVA of 4.2, and with the intracorneal rings and cross-linking is going to be 0.4, but with a very aberrated cornea, and this case is not going to have a happy life with this quality of vision. This is the point. So for me, there is a limit which is about 0.2 BCVA pre-op. In whatever we do, we shall stabilize the cornea, etc., but finally the vision will not be good enough for the patient to be satisfied. What do you think about this, Alain? Because you practice corneograph frequently, so for you, this is a frequent decision when to decide corneal transplantation surgery, DALC, precisely, in these cases or not?
Well, I think that's a very important question, and the missing information is we need to know what are the results of DALC. If we can achieve the same results with any other laser or crosslink or any other modality, then it's okay. But in many cases, I see patients who go and have crosslinking and then rings and then excimer laser, and then all this will decrease their chance to have a good results after DALC. So I think DALC is underestimated. First of all, we need to know that the results of DALC are very good. I'm talking here about DALC, not DKP. These patients are young. They will live long life with their endothelium, no risk of rejection. If you do today a large graft, usually you get an excellent outcome. So my point is, I don't want the patient to lose time and to lose effort and money and go and do many procedures, and then at the end you will have DALC again. So the baseline is we need to know, each surgeon needs to know what are the results of his own, of DALC is in his own hands, and whenever he can achieve this result with other modalities, it's well and good, but in many cases, DALC will give better results than other modalities, especially in moderate and advanced keratoconus. Of course, not in early cases of keratoconus.
For me, 0.2 or less is for cornea graft, because whatever we do will not be providing good vision for the patient. Theo Seiler is here, and he uses different approaches than Fahad Hafesi to cross-linking. You use different technology. Which protocols do you use, and when do you apply them in keratoconus, Theo?
So first of all, we're using the customized cross-linking approach as something very similar to what FAIRY does, just another technology, whether we use a device that applies the customization or whether you do it how he does it with PACE. So I think the approaches are pretty similar. It's just the way how to achieve it. The results are also what I've seen so far from FAIRY. The results are also pretty similar. So that's so far for cross-linking. The other thing with cross-linking, you always have to discuss whether you want to enhance it by the use of supplemental oxygen. We just submitted a publication with supplemental oxygen epi-off versus the regular customized cross-linking epi-off. And you also have a higher chance, like all other procedures, also with the eczema, to get a stromal scar, and therefore also reduce the visual acuity. So you always have to think, if you enhance the treatment, you also can buy in some disadvantages. Regarding the question of keratoplasty, I think scleral contact lenses are really very powerful, and I also have the opinion that as long, even if you have a visual acuity of 0.2, 0.1, best speckle corrected, you don't need to perform a keratoplasty immediately, because if the patient has an acceptable visual acuity of 0.8 with scleral contact lenses, I probably would not do a DALC in those cases.
Paolo, you are one of the defenders of epi-on procedures. And when do you use epi-off? Because epi-on is your regular practice with iontophoresis, right? So for you, there is any indication for epi-off, or do you practice epi-on in all cases?
So, first of all, it depends by how much is the grade of the cone. So it's very distorted cornea. I still use, let's say, a customized cross-linking like Faraday's teacher to us that is so effective. But the benefit of iontophoresis is that do not leave you to surprise. What we are faced at recently, following our patients since already 15 years, that we have patients where I was so satisfied to see that over time, the flattening of the cone till a range where it almost disappear. Then suddenly, after 3 or 4 years of completely looking like normal cornea, I observe a massive flattening. So people with the EP off, so people who has +6 in 2-3 years between the 11 years and the 15 years of follow-up. So completely unpredictable and completely not time dependent, but patient dependent. So the benefit of the iontophoresis that we do not never face those large flattening or massive flattening. So for people who has a very starting good visual acuity is so safe, in my opinion, that is the chosen technique for me. For patients who see very well 0.8, 0.9, but have very young but progressive cone, the iontophoresis is very, very effective.
Good. And Sayed, you have a large experience in intracorneal rings, and obviously cross-linking is necessary because rings do not stabilize the keratoconus. So the frequent debate is whether should be performed the cross-linking after, before, or at the same time. What is your practice and what is your evidence?
Thank you very much. From the evidence base, there is no differences between the cross-linking before the intracorneal ring segment or after the intracorneal ring segment 6L in the progression of the keratoconus disease. But I prefer to do in the progressive cases first intracorneal ring segment implantation, and after 4 weeks or 2 months cross-link, the patient candidate for the cross-linking. But the literature and the literature review shows that cross-linking before or after the intracorneal segment has no different significant change or differences between these the two methods. So I prefer to, in a progressive cases, first implant intracorneal ring segment, and after 1 month cross-linking. In a stable cases, just I prefer to input the intracorneal ring segment and follow every 3 to 6 months. And if any evidence of progression occur, then I decide about the cross-linking in these cases. Okay.
Very good. And Professor Maldonado, how do you use associated cross-linking and rings? Same time or different moment? Because there is evidence in favor of doing simultaneously, but the practice usually makes a big difference in terms of the decision of doctors. So what is, in your opinion, the best option of all of them?
Yes. Personally, I rather see the effect of intracorneal segment implantation, see that is as good as I am expecting. Sometimes it's been scarcely, but I have had to add one more segment to achieve the result I was expecting. And once the result is achieved with the rings implanted, then I try to freeze the result with cross-linking. That's the way I prefer. So first intracorneal segment implantation and then cross-linking. That's my favorite approach.
I do them, both of them together, you know, and I follow the studies of Doyle Sturtin in a prospective study that it was quite evident for him that simultaneous treatment was more effective, but still the practice is not that much consolidated. Professor Teus in Madrid, he has extensive experience on that. And what is your position at this regard as well? Same time, different time, sequential?
Well, I think my personal opinion is that first, as Professor Maldonado has already said, first put the rings inside, then once the shape of the cornea has changed, then try to freeze it with cross-linking. So that's my approach.
You have, you are the author, let's say, of the Cretan protocol. That is the one I follow. Let me tell you that I am your follower, and with very good results. So definitely this approach to ablate the epithelium in a way that you can decrease the cone and to flatten it, decreases the cone aberration clearly, and this improves the vision. So do you have any role, or do you leave any role for the customized PTK as other authors have been proposing? Because in your presentation you say clearly that you are not using them at all. Is that correct?
Yes, and actually, maybe Farhad may comment on that. I cannot understand the difference between the Cretan protocol, transepithelial PTK, and his new approach, PACE, which is, it's the same rationale. So you just ablate the epithelium and the bowman, and you achieve a customized cross-linking because the UV light penetrates deeper than the rest of the cornea. And I agree with the previous speakers that the major issue for me now is the over-cross-linked cornea. I'm dealing with corneas that cross-linked 10 years ago with a deep cornea scarring, and I have major difficulties to perform a DAT, like Alain mentioned this. And I think over-cross-linked cornea will be the future problem for us. With deep cornea scarring, progressive flattening, the only way to deal with them is to find which protocol is suitable for every patient. Maybe Ferry.
Okay. Yeah. Well, it has been the debate for many years. Yeah, whether the PRK, customized PRK, should have a change in the profile once that the cross-linking is already with a full effect. And this is one of the issues. This is why it seems to me that your protocol, ablating the epithelium, makes more sense, because changes are just to be in the benefit of the vision. This is my opinion. And other thing is that whether this should be the approach in every one, because that implies that you use epi-off technique, while the epi-on, as Paulo Vinciquerra has mentioned, has a very important role, and for the patients is much more comfortable. There is not clear evidence that is better epi-off than epi-on, other than the effect that you gain with performing the PTK. Do you agree with this? Question is for you, George.
Sorry, I have some problem. I cannot hear you very well. Could you please repeat it, your question?
Right. Well, I think that we compare the epi-off and epi-on. The advantage of epi-on is the comfort of the patient. The effectivity seems to be the same. But in epi-off, the advantage is to ablate the epithelium, decreasing the cone. This is the main issue. So in my opinion,
exactly,
when we have patients in which BCVA can be improved, and many of them, obviously, they can, your protocol is better than the epi-on, while if the cases have already a good BCVA, probably epi-on is the procedure to perform. My question is whether you agree with this point.
I totally agree. And, the ablate the epithelium, it's the simplest way. It's very simple. You don't need all these fancy devices like tomographies and other things to measure the aberration and other things. And we compare the Cretan protocol with other protocols, and we found that we have faster epithelial healing and better visual acuity. So that's why I'm doing the last 10 years, and we have long follow-up, long-term follow-up over 10 years, and we don't have any issues with over-cross-linked cornea, which is for me the major problem now.
Very good. Obviously, we are dealing with a huge topic. Keratoconus was a marginal issue years ago, and now has moved corneal surgery to another level. And there are many questions that we could make and many points that could be addressed in this discussion. Obviously, we don't have the time. Dr. Maldonado, do you have any conclusion to bring about the session, something to add to it? Because we're going to close the session.
Yes, I would like to point out how these kind of approaches are being more personalized, more customized, and we see that by the use of different influences, different approaches for creating a gradient of effect of the cross-linking, we are improving the results of the very early stage cross-linking. So this combined with other techniques that have been extensively covered in this session, I think we have a portfolio of different approaches that are covering most of the needs of our keratoconus patients today, and we still have the opportunity to end up with a keratoplasty. So I think it's been a great session with a great update from these experts. Thank you very much.
Okay, thank you very much. And I think all of you to be here at this time is late. For Allah, it's very late. Definitely for us, it's a little bit less, but all of you has made a very significant effort to be with us in this session that, in my opinion, is going to be very useful for all our virtual attendees. So thank you very much indeed, and I hope that this year we shall have new perspectives in keratoconus as good as we had this year. Thank you very much. The session is closed. Thank you.